Hi, everybody. We're back again, continuing our day. We've had a stellar time so far. I am super excited for our next speaker, Christy Gray. I feel like I know her so well, even though I've never seen her in person, but I know she exists because I now see her moving around. One of these days, Christy, you, Rebecca, and I are going to have lunch like real people, but I still feel like I know you well because I've talked to you so much. Christy Gray is our director of immunizations for VDH, and she's been working for the Division of Immunizations since March of 2009. And she initially served as the Virginia Immunization Information System regional consultant, trainer, and also subject matter expert on the epidemiology, surveillance, and prevention of vaccine preventable disease. She has served as the senior manager for the Growing Viz program, concentrating on data quality, data exchange, and strategic planning. And as I said, she's been the director of the DOI since June of 17. And in the pandemic response, where Rebecca and I have really got to know her, she's been instrumental in standing up, standing up for initial testing in Virginia, and has been one of the co-leads of the Virginia COVID-19 vaccine response since July of 2020. And I can personally attest to how hard Christy and her entire team have worked throughout this pandemic. But I would also like to put in a word here how utterly supportive she has been of our coalition, and she has consistently supported us, made herself available to us, or provided us with her colleagues that can further us along. So it's really an honor and a pleasure to have you, Christy. You are one of the hardest working people I have known. So take it away.
Thanks so much, Dr. Moneymaker. It's a pleasure to be here. It's something that we've been looking forward to for so long. If you remember back in March 2020, we were supposed to have this annual meeting, and we were all excited about it. And then the pandemic hit, and it was really important for VDH to stand up our state immunization coalition, since the last one had stopped in earlier in 2010 timeframe. And so we know how important Immunize Virginia is to ensuring protection against morbidity and mortality of vaccine preventable diseases in Virginia. And so we are Immunize Virginia is a partner to VDH. We see how important you are and want to support you moving forward. And there will be more meetings in the future that I hope to greet everybody in person, and we'll have those drinks, Dr. Moneymaker, or go for coffee or just hang out in person. It'll be very exciting. So today I just wanted to talk about lessons learned from the pandemic and implications for the future. So there's a lot that's happened in the past 19 months or so that we've been dealing with this, that just really has changed a lot of, if you remember, H1N1 happened in 2009, 2010. I was with VDH at that time. I just started, and it is a world of difference between how we handled that and how we're handling the current pandemic. And hope to talk to you about that today. And hopefully we'll be better prepared in the future for any other ones that come our way. Next slide. All right, so I did want to give you an update about where we stand with COVID-19 vaccination in Virginia. Virginia is doing extremely well. We have 79.8% of adults with at least one dose of vaccine, and 71.1% of adults are fully vaccinated. 67.2% of the entire population has one dose, and 59.7% is fully vaccinated. If you think about that, the age of children 11 and younger can't even get a vaccine. So we are doing an excellent job about getting Virginians vaccinated. We're very proud of this, but it is not consistent across the state. There are pockets of less vaccinated than others. So we cannot stop yet. We still need to get at a higher level statewide, but also really concentrate on those areas that are either have access or hesitant issues associated with this vaccine. And we really want to meet them where they're at to ensure that they are protected as well, because as you all know, vaccines only really work, they work great to protect ourselves, but they work best if everybody gets them, or at least most people get them. I also wanted to highlight, we have 10 million doses have been rolled out through this program in the past 9 months. This initiative and public health response is once in a lifetime, knock on wood, that has happened, and we're very proud to be part of it. It's more than a total of 5 years of vaccine for children vaccines that have been rolled out. This is an amazing effort that has been a true partnership between public health and private providers, hospitals, pharmacies, FQHCs, all of our partners, and then community-based organizations that are helping to spread that information to the public on why it's important that they protect themselves and others. Next slide. So I just mentioned our partners in providing vaccine in Virginia. One really interesting piece that came about over the past year is how important pharmacies were to this outreach, and how this will set the pace for, we can look at this moving forward with other adult routine vaccination, flu vaccination, to really include them as a great avenue that's very convenient. 95% of people live within, 90% of people live within 5 miles of a pharmacy. So it's a very convenient location for somebody to get vaccinated, and they will continue to be a very important partner that we should remember and continue to work with as it relates to vaccines. And then, of course, everybody it did contribute to this, and it had their own part to play. For example, hospitals played a huge part in vaccinating our healthcare personnel, as well as there stood up several different community vaccination centers or community vaccination locations throughout the state that they opened up to their communities. Our local health departments have been just going like Energizer bunnies for the past 19, 20 months, doing everything, and really were able to get out and focus on those populations that are hard to reach, and that we really need to add a little bit more outreach to them to meet them where they're at and answer questions that they had. And then our private providers were also instrumental in vaccinating their patients and having those hard conversations with people that have questions about these vaccines, and we want them to ask these questions. We want them to get informed from a credible source like their provider. There are several studies that have shown that a provider's strong recommendation of a vaccine is one of the top motivations or top top things that would motivate somebody to consider getting vaccinated. So they are also crucial to this effort. And that also falls along with our community health providers, our FQHCs, other partners that worked with us to reach other populations in the community that they had that access to, and that trust to be able to bring the vaccine to and get them vaccinated. So this has definitely been a effort that required multiple channels to get vaccines out to the public. and all of which were very, very important. Next slide. And I did just want to take a moment and go over the since December, how vaccines got rolled out. Most of our vaccines in Virginia, as well as the U.S., were either Pfizer or Moderna vaccines. They did come out earliest in December, and J&J came out at the end of February. But the amount of contract purchase of these vaccines was just higher. The U.S. purchased more Moderna and Pfizer vaccine, but we do have J&J vaccine in Virginia. I did want to point out too, well, we obviously started in December and we creeped up and really peaked in April, May timeframe, where we had all our vaccine channels on all cylinders going and vaccinating just thousands, hundreds of thousands of people a day. And then we kind of went down into the May timeframe, and that's when children 12 to 15-year-olds were recommended to get vaccinated. So we had another bump up. You can see that in May, and then a decline into the summer. And then although we were on the downturn in July, we actually creeped up a little bit. And we do think that is because that is when the Delta variant started to really cause a lot more infection and illness, hospitalization, and death. So we did see the people recognizing that there is that this the Delta variant at least is causing much more severe illness, and that they wanted to get that protection with the vaccine. We were able to reach 70% of adults with one dose at the end of June. That's ahead of the Biden administration's goal of July 4th. So we were really proud of that. And then we're also hit 75% of adults with at least one dose about August 22nd. And as I mentioned before, we're about to hit 80% of adults. So we are progressing onward, even if it's not at a sharp increase, it is steady. And we want to continue to see that and reach those remaining persons that are still not sure and just need a little bit more information to make that decision. Next slide. All right. So I did also want to talk to you about the percent of vaccination of COVID vaccination by age. This on the left-hand side, you have at least one dose, and on the right-hand side, you have fully vaccinated. It usually differs by about 8 to 10% delay, just because you do have a certain interval between getting your first and second dose. And those that have received J&J vaccine, which is only one dose requirement, would once they get their dose would be following into both of these categories. As you can see, our older population is much better at getting vaccinated. They, especially at the beginning, were also at much higher risk of illness, and so we are glad that they are making those decisions to protect themselves. And the younger population is trailing a little bit. I mean, even if you were to look at just 20 to 29-year-olds, they're actually our least vaccinated decade of group, our 20 to 29-year-olds, so our invincibles. And so we really need to, we're working to try to reach them and determine what's going to, do they have concerns? Is it apathy, or is it actual concern? And is it an access issue? There's lots of things that we're trying to dig in to reach that population, because again, vaccination works best if most people are getting it. Next slide. Okay, so percent vaccinated by race, ethnicity. Virginia's really strive to reach parity with our vaccination across races, and parity means that we're comparing how the rate of vaccination against the rate that whites are getting vaccinated. And so if you see in the really the only race, ethnicity that is not getting vaccinated at that rate is Black population, but it is much closer than it was at the very beginning of the year. So we're proud we're making that closing that gap, but there's still work to be done. Also want to draw attention to our Native American population. I know it's 103%. And that really goes to just the imperfection of how we calculate race in our systems. It's not the same as how we view them in real life. And we're using slightly outdated census data here. So it's could be that the amount of people that are identifying as that race aren't necessarily matching with the outdated census demographic denominator data. And we're looking at updating that soon. But yeah, this is a known, it's been acknowledged by systems in general, just that, it's often people are not just one race. And so we're trying to work through how we can better view this to try to find disparities, but also reflect it to the situation. Next slide. All right, so I just wanted to go into our lessons learned and implications for the future. So what we did find with the pandemic is that routine vaccination suffered. When the pandemic started, everything shut down and people were not going to getting preventative treatment, preventative appointments. So they're not getting screened, they're not getting the routine vaccination. A lot of stuff was put on hold. And so that's something that we want to ramp up for and plan better for too, in order to prioritize and catch up kids. What was good about this is that we did prioritize children 24 months of age and younger to, if you had short staff at a provider's office and you could only see so many people, prioritize those young kids to vaccinate them, because that is where you're getting your primary series in to protect you against the vaccine preventable diseases in the future. The older kids usually already have at least one of those doses in their system, or they are getting their adolescent vaccines, which are still very important, but they are not necessarily as communicable in the everyday life during the pandemic. And so we are still watching that and trying to get our adolescents caught up. They suffered the most, but I still think would be better than having a generation of young kids that did not get vaccinated against measles. So we are going to be thinking about that moving forward. New vaccine technology, the creation of the mRNA vaccines really allowed us to create vaccines much quicker than we have been able to before. And I think that will, in the future, be allowing for more efficient vaccine development. We can respond more quickly in the future than we would have if this technology had not come about. So that's very exciting. Partnerships were so crucial and remain to be so crucial, not only for during a pandemic, but utilizing those same partnerships to continue with other future vaccine efforts that we want to undertake. So if we want to increase outreach to vaccines for adults, or increase access for vaccine for children providers, these are different things that we can utilize our partnerships that we've made to improve other vaccine efforts. Equity lens. So one of our main things that we always tried to do during the pandemic was ensure we were doing all planning and implementation using an equity lens, and understanding that to ensure that access to this vaccine is paramount, and that we're not making decisions outside of that lens, and making sure that just because it's easier or convenient to go one way doesn't mean that we go that one way. We have to make sure that we are providing everything we're doing is inclusive, to make sure that everyone does have access. And that's something that we need to continue in all of our efforts moving forward with any vaccine work here at VDH. Data-driven decisions. So a lot of what we did this year was based off of data, and which was important to be able to forecast what we might need, what we might not need, when do we need to ask for more resources, where do we need to place different resources, and that is going to data is going to continue to be king. And it's going to have to drive our strategy moving forward, and we need to make sure not only that we have data, but that it's good data. and that we're making those decisions based off of that we have access to. Next slide. Okay. So another big thing that happened this year with the pandemic is that if you administered a COVID vaccine, you had to report it to the Virginia Immunization Information System. Currently in Virginia, reporting vaccines administered is not required. And so this was important in order to be able to have a clear picture of everything that was going on in Virginia. We needed to know where a vaccine was being administered, where was it not being administered, where was there gaps, and where were there supply issues. And that really allowed us to not only meet our CDC requirements to provide them the same information, but also allowed us to make those data-driven decisions that we needed to make. And so we do see that this will continue to be important. And so we need to ensure that we're investing in this, where we are putting in needed infrastructure upgrades or other application code updates, and bringing in what we need to make it as robust as possible and as efficient to use and interact with as possible to our users and to our partners through data exchange. All right, and optimizing vaccine channels. I did talk about this earlier regarding our different partners that we worked with to get vaccine out to the public, and just mentioning how important the pharmacies were. And the SSRP is a small shipment redistribution program. And that's a program we started in June to break down vaccine shipments into smaller amounts and send to providers who couldn't handle the amount of minimum order capacity directly from the manufacturer. This was key to allow a provider to participate and get access to vaccine when otherwise they wouldn't be able to, because they would have too much vaccine and it would have to go to waste, or they didn't have the storage space for it. And so this really allowed us to expand access to more providers, which meant to more people that wanted to talk to their doctor, wanted to get their vaccine from their doctor. And so, of course, looking forward, we want to continue to bring in pharmacies into all vaccination moving forward, but also setting up a state depot like this sooner. Our Division of Pharmacy Services here at the Virginia Department of Health runs the SSRP. And so setting that up sooner in a pandemic, I think, would help bring providers in sooner into that response. And then misinformation. I know that Dr. Offit spoke earlier. Misinformation has been such a huge part of this pandemic in so many different forms. But something that we've really learned about it is how well funded and intentional this is. It is not a random person who's doing something on their computer and sending something out. This is a organized, intentional, and well-funded effort and it needs to be met with that reality and with that seriousness and the reach that it has. And so we are continually learning about what they're putting out and how to address it. And then communication to different audiences. So I've been learning all kinds of new platforms that exist these days. We have the traditional platforms of reaching people, but then, not everybody uses those traditional platforms, just like not everybody uses newer platforms and where they're getting information. And so the variety of how to get information out to people is so vast that it is even more important to invest in that kind of communication campaign and people who know how to reach these different populations and what works, what clicks for each of these populations. How do you reach them? And then finally, flexibility and adaptability. So that is something that was so crucial to be able to be responsive and roll out what we've done so far, and would be crucial in any kind of campaign in the future, because even this week, with, as I'm sure some of you have seen the media, with lots of decisions happening with vaccine boosters, things happen so quickly sometimes, and you have to be flexible and adapt. If the data is showing that something's not working, you have to adapt. Or if decisions come down, you have to adapt, and you have to be able to roll with it and be flexible. All right, next slide. Okay, so that's all I had today. I'm happy to answer any questions, and love to hear from you.
All right. Thank you so much, Christy. Just getting reconfigured here. What a wonderful presentation. We only have about a minute or two to answer questions before we move to our next speaker. So I will go ahead and just put the first one on here. I was introduced to the pandemic planning almost 2 decades ago. Many of the lessons you featured and others have been presented repeatedly over time as successive challenges have arisen, and the knowledge, however, doesn't stick. So we have to reinvent the wheel in short order and under crisis conditions. How will VDH deal with this crucial learning disability?
Thanks, John. Yeah, so we do have opportunities to sit down and discuss within the agency lessons learned, things that have ways we can adjust and change in the future. And I do think that unfortunately humans sometimes get complacent when you haven't had to deal with it, right? And you don't necessarily you're not doing it day to day, and so you've moved on, and you can and you don't always remember those things at first. What I will say is that and something I didn't mention was a lot of the things that you'd want to do, unfortunately, you can't always control. And so when you are able to control them and you can take action, that's when we can actually do what we'd plan to do. For example, with COVID, we were planning from July to December on what we needed to do, but we weren't given any funding to do it. So there was, and the funding arrived about mid-January from the CDC, which allowed us to finally hire staff, put into place contracts and things like that. So there's definitely some things that we want to. Planning doesn't necessarily always mean you can take action. And sometimes things are delayed longer than you would have liked to because of this lack of control in some situations. But we definitely can always continue to improve, and I can take that back to VDH and make sure that we are considering that when we are doing our meetings where we're debriefing and talking how we can improve in the future.
Well, thank you so much, Christy. We really, really appreciate your time. And like Carolyn said, we know that you have been working nonstop with your team to get us to the point where we are. So we just want to really thank you for that. And Carolyn, I will turn it back to you for any closing questions or closing words.
Christy, I just have one question. Is the third booster for Pfizer, is that going to is that going to impact you all terribly, or is that just business as usual?
Maybe a little bit of both. We have been doing modeling of the booster planning for about a month now, expecting that it would be coming. We've been doing several different analyses based off of what the recommendations might look like, looking at 6 months versus 8 months versus certain populations, and doing that evaluation based off of the district level, because every district has different resources and has different populations that might need to handle or have different solutions to reaching their population. So we've had those meetings and planning, and the recommendations are showing right now are indicating that we will be standing up community vaccination centers in Virginia, just like we did in the spring and summer. And those districts that we've identified would have excess doses that would not be able to be met with the existing channels. We're also supplying other districts that have excess doses, but not as much, with a more mobile solution where it's not a standing location that's open 6 days a week, but they move around to where it's expected people would gather to be vaccinated. And that will be combined with communications with the district to identify where those locations are and providing notification out to the public so they know where they could get their booster. And that is in addition to the existing provider channels, pharmacies, hospitals, providers, and local health departments that might be holding their own clinics. So we're hoping to provide more guidance to the public and our COVID vaccine providers today and the following days as more information comes out.
Okay. Well, good luck.
Thank you so much for having me.
Thank you for coming.
All right. Thank you. We really appreciate you and all the work you're doing. We will pause the broadcast and resume in just 1 or 2 minutes with Karen Ernst from Voices for Vaccines. So thank you, and you'll see us again in just a minute.